This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. And we thought we would talk about gallstones and some of the treatment today as opposed to how it was treated previously. We've got Dr. Scott Bloemendal with us. He's a general surgeon at Texas Health Harris Methodist Hospital in Fort Worth. Dr. Bloemendal, welcome to the show.
Thank you very much. Thanks for having me.
You know, to help our listeners understand, let's set the stage. What exactly is a gallbladder, and what is the purpose of this organ?
Well, those are great questions, and I get those questions on a daily basis. The liver makes bile just about every day, and this helps you process fatty food. And so the gallbladder just serves as a storage pouch for this bile, and that's kind of kept in reserve for when you do eat a fatty meal with fried food or greasy food. And that's when the gallbladder contracts.
You know, sometimes people develop gallstones. What causes these, and how frequent do you see that with patients?
So gallstones are actually very common. So it's estimated that about 6% of the U.S. population, 6 to 9%, will get gallstones at some point. Now, not all of those cause symptoms, but about 25% of patients will get symptomatic gallstones. And those stones are usually made of cholesterol deposits, and most of the time that's because of our diet. So things that we're eating are causing too much cholesterol for our body to process, and that extra cholesterol is being deposited in the gallbladder, and that forms into stones.
So let me ask you a question just as a layman. If you have gallstones and it's from cholesterol, would it indicate that maybe you should be checked for cardiovascular problems?
So that's a great question. The absolute level of cholesterol in your blood doesn't always correlate with forming gallstones. Not everybody with cholesterol gets gallstones, but if you do get gallstones, then absolutely you should have your cholesterol checked, and then that may lead into getting cardiovascular evaluation as well.
If an individual is developing gallstones, what are some of the signs or symptoms associated with that?
So we see this very often, and so if you have gallstones that cause symptoms, the most common symptom to watch for would be pain in the right upper abdomen, and that would be right underneath the rib cage. That pain is often associated with nausea or vomiting. It can also cause loose stool, and so we see this often when the gallbladder gets blocked by a stone, and then once that stone rolls out of the way, it can go away completely. So at first, the symptoms are very episodic. So they'll come and go, and they can last 30 minutes, they can last several hours. And once those symptoms progress, it can eventually lead to much more serious symptoms like a bad infection in the gallbladder, or it can cause blockage of the liver, or even cause pancreatitis.
You know, that sounds quite serious. And when you first described those symptoms, I thought of appendicitis almost. Do sometimes people think they have gallstones and it's appendicitis?
So sometimes people can think they've got either appendicitis or even reflux disease. That's a common thing that we see. It's often hard to distinguish reflux disease or pain in the upper abdomen from gallstones. Usually appendicitis is in the right lower abdomen, so it's not as often a concern.
Are there any specific tests that you can run to confirm, yes, this is gallstones?
Absolutely, yes. The best test to look for gallstones would be an abdominal ultrasound, and so that's a very straightforward, simple test that uses sound waves, and they just rub some jelly on the abdomen, and they can actually see the gallbladder really well and determine whether there are stones or even sludge in the gallbladder. So that's the best test. There are other tests that might show gallstones, like a CAT scan, or a sonogram through an endoscope. But that's the mainstay of diagnosis is the ultrasound.
How has treatment of gallstones and gallbladder surgeries changed over the years?
So that's a great question that I get often because, yeah, some patients will remember times about 30 years ago where the only way to take out a gallbladder was with a big incision in the right upper quadrant. And so that would follow the rib cage, and it's a big incision, and yes, patients would probably be in the hospital for several days. But in 91, the laparoscopic gallbladder surgery started here in the U.S., and we've actually been doing that for quite some time now, which is great because it's a nice outpatient surgery. It usually takes about an hour, so the recovery period is much quicker, and it's typically done as an outpatient where the patient can go home the same day.
You know, it's a tremendous advancement. But are there other options other than surgery or other treatments that you can use for gallstones?
So gallstones are difficult because there's not a whole lot of other things we can do to treat gallstones. Compare that to kidney stones where they can be blasted with sonogram or sometimes even dissolved. These gallstones, once they form, there's not good medicine that we can give to get rid of them, number one. And number two, they can't be blasted with sonogram because they will potentially cause pancreatitis because the pancreas duct is downstream of the gallbladder. So really the mainstay for treatment is to actually remove the gallbladder, which removes the stones inside, but it also removes that little blind pouch so that gallstones never form again.
Can a person function normally without their gallbladder?
Yes, absolutely. And to clarify, we always remove the entire gallbladder so that the stones never reform. When we're taking out the whole gallbladder and all the stones, that patient's going to function just fine long term. So it turns out you don't absolutely have to have a gallbladder. It's not essential. And the patient's digestion will still be fine. So you can still process greasy foods because the liver still makes bile every single day. And so most patients don't notice any problems. There's about 5% of patients that develop a little bit of diarrhea after surgery, but that almost always goes away.
Are there things that individuals can do to reduce developing gallstones?
Yes, absolutely. I mean, the problem with all of the things that we eat here in Texas is that we end up running into a lot of cholesterol and fatty foods and fried foods, and just limiting those in our diet can definitely help to lessen the risk of forming gallstones. Keeping our weight in check is important because patients have a higher incidence of gallstones. And those things alone will significantly reduce the risk. There are some patients that have a strong family history of gallstones, and so they have a predisposition to forming those stones. But in most cases, there is a dietary component. And so by controlling your diet and helping to lessen your fatty food and cholesterol, that can help put you at lower risk of gallstones.
Dr. Scott Bloemendal, a general surgeon at Texas Health Harris Methodist Hospital in Fort Worth. Wow, who would have thought this was so important, especially with the cholesterol? More on our gallbladder next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're continuing this conversation about our gallbladder. This is Dr. Scott Bloemendal. He's a general surgeon at Texas Health Harris Methodist Hospital in Fort Worth. The entire interview, by the way, is on our podcast, The Human Side of Healthcare, and our YouTube channel. In the last segment, we were talking about cholesterol tied to this. Dr. Bloemendal, is genetics also a piece of it?
So that's a great question. The majority of patients do have a dietary component, but certainly there are some family history components to this as well. There are things that can put a patient at risk for gallstones. For instance, we see this often with pregnancy. Something about the milieu of progesterone and estrogen causes the gallbladder not to drain properly, and so it can form stones. So we see patients that have just had a delivery and have gallstones right after that delivery. That's pretty common as well.
Okay, let's circle back to the cholesterol because this is an interesting issue. So could a statin or other cholesterol treatment also be a viable treatment for gallstones?
So the statins really do help decrease levels of cholesterol in the blood, and that primarily affects the cardiovascular system. So that's going to help for sure in lowering your cardiovascular risk. It's not necessarily directly correlated to helping you avoid gallstones, for instance. They've done studies, and it shows that not all patients with high cholesterol get more gallstones, and the corollary to that is patients with low cholesterol, they can absolutely get gallstones. So it's something about the way your body is processing it that's the problem. It's not the overall number.
Got it. And that's a great picture for us lay people, Steve. So this is more of on the digestive end, and what the cardiologist would deal with would be more of after it's in your system, after it's passed through the gallbladder. Is that right?
Right. The absolute number that's floating around in your system is much more important in avoiding causing problems with your heart, and not as important in the way that the gallbladder is processing things when you're eating greasy foods.
Got it. Okay. Thank you for that distinction. And then you guys also talked about the progression of this. So you start to have greasy food, and then maybe you have a little problem, and then you just went through a ladder of progression with Steve earlier. Is there a way to catch it before, like, okay, you get the warning sign? It's almost, I'm thinking almost like pre-diabetes. It's reversible if you make changes. Is this the same kind of thing?
So it is important to catch it early, and so very unlikely for a patient to present with one of those severe complications as their very first symptom. Usually those patients have had symptoms for some time, and it might have been overlooked. So it's important to catch those symptoms early. So if they do get pain in the upper abdomen, especially after eating greasy foods, or nausea or vomiting that's associated with eating, then those symptoms will typically come and go, and often patients come to us after having had several months of symptoms, and that is the key, is that if they catch it early at that time before it develops into any of those other problems like liver jaundice, pancreatitis, or a completely blocked gallbladder that causes a bad infection, if they can catch it early, then they can get their gallbladder out as a nice outpatient surgery electively and not have to end up in the emergency room, which is almost always at 3 a.m. with a fever of 102, and those are much more serious developments.
Not a good path, right? Exactly.
Right.
So what about if you have those early symptoms and you radically change your diet? You go to vegetables, fruits, moderate amount of protein, and you eat a lot of salad and greens, etc. Would you possibly reverse it?
You can absolutely decrease the incidence of you turning into a patient that needs their gallbladder out. So overall, if 6 to 9% of patients get gallstones, that means that not all of them become symptomatic. So yes, if you switch to a low-fat diet and are very careful about keeping your weight in check, then yes, you can avoid symptoms and may end up never needing that gallbladder out as long as you maintain that diet.
But generally, once you have it, you're going to have it.
Generally, once those symptoms start, then yes, because there's not any good way of getting rid of those stones, you can lessen your symptom risk and you can go on for quite some time lessening those symptoms, but at some point those gallstones may cause problems down the road. So it's important to see a physician and just make sure that you're not going to end up being one of those patients that progresses to a much more serious condition.
So when you remove the gallbladder, is something bypassed or reconnected, or how does its old function resume after its removal?
So the nice thing about that is that because the gallbladder is a little blind pouch, there's nothing else that's connected to it. So when we remove the gallbladder, turns out your body doesn't have to have that function. So the liver still secretes bile through the bile duct into the intestine, and that is never disturbed. And so the liver still makes that bile that helps you digest those greasy foods. So you just don't have to have that gallbladder function. It's just not essential.
I know we've talked about this before. Steve and I both had our tonsils out back in the day when that was in vogue to remove them. Is that kind of the same type of thing, that it's like one of those things that once you don't have it, you don't miss it?
I think that's exactly the case. Yes, it's like that for the gallbladder, and it's also like that for the appendix. Turns out those are not completely essential. They do have a function, but the body does perfectly fine without it. It's remarkable that the body can adjust and compensate for not having it.
If somebody had a procedure on Monday, when would they be back to work?
So that's a great question. The only thing that you can't do after surgery would be any significant lifting. So if their job requires a lot of lifting, then we don't like patients to lift more than 15 pounds for 3 weeks after surgery, and that allows those incisions to heal. If they have a job that doesn't require lifting, then they'll typically be back to work within a week. And so if they had their surgery on Monday, they would go home that same day. Most patients would only take about 2 days of pain pills, and then by day 3, they're off of pain pills, they're recovering at home, and then they can go back to work pretty soon thereafter, so within 7 days usually.
So other than the entry, breaking the skin and entering, what else is affected inside that heals?
So the healing is primarily just right where we take the gallbladder off. It is attached to the liver, and so there's a small portion of the gallbladder that's sitting right on the liver, and so that does take some healing, and so there's some inflammation, and that's where that pain for a couple of days sets in. But then after that, you get over that pretty quick, and then you have the 4 small little laparoscopic incisions that do require some healing, but that also heals up pretty quick.
Now that's interesting. So you mentioned it's attached to the liver. So is it subject to developing cancer? Can you have isolated cancer of the gallbladder?
So you can. It's extremely rare. We don't see gallbladder cancer very often, and once we see it, it's usually pretty advanced. It's one of those cancers on the list that you don't want because it's typically undetected, and it can erode or invade into the liver at a relatively early stage. So we don't often see gallbladder cancer developing, and that's probably because the inflammation that causes gallstones and causes patients to get their gallbladder out likely never progresses to the level where it would cause cancer because that gallbladder has already been removed.
And then likewise, can it move from the liver to the gallbladder, or is liver cancer in a different region, different zone, usually goes a different way?
Liver cancer is usually a totally separate process, so it doesn't usually involve the gallbladder. Gallbladder is kind of on the periphery of the liver, and so those liver tumors don't typically involve the gallbladder.
Excellent. Great. Well, this has been very educational. Thank you.
Do you have any closing thoughts or nuggets of information related to the gallbladder, gallstones that you would like to share with our listeners?
Absolutely. So this is one of the most common operations that we do, and they say that there's about 600,000 of these operations done in the U.S. every year. So this is a common thing. So patients that have these type of symptoms don't need to be too alarmed about them. We can take care of that with a nice outpatient laparoscopic surgery. And if they have any questions, then either seeing their primary care doc or a GI doc can help sort this out and determine whether it's gallbladder disease or reflux disease. And if it turns out that they do need an operation, then that's a pretty straightforward thing that we do, and nothing to be too worried about or concerned about. We can talk them through it.
We've been listening to Dr. Scott Bloemendal, a general surgeon at Texas Health Harris Methodist Hospital in Fort Worth. We've seen it over and over again on the human side of healthcare. Diet and exercise make all the difference. And check out his full interview on our podcast and YouTube channel under the human side of healthcare. Now, when we come back, it's Epilepsy Awareness Month. Dr. Scott Perry from Cook Children's joins us next. Stay with us.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome to the human side of healthcare. Delighted you're with us today. And November is Epilepsy Awareness Month. And there's been a lot of advances in the therapy and treatment of epilepsy. So we thought it would be a great time to bring in Dr. Scott Perry, who is head of Neurosciences at Cook Children's. And Dr. Perry, welcome to the show.
Thanks so much for having me.
You know, as we kind of begin this discussion, for our listeners out there, can you give your definition of what epilepsy is?
Yeah, absolutely. In the simplest terms to understand for people, epilepsy is the tendency to have more than one seizure. So, many people may have a seizure in their lifetime. In fact, 1 out of 10 people will have a seizure in their lifetime. But some people will have an underlying tendency to have repeated seizures. And when you have repeated seizures, that's what epilepsy is.
So how common would you say epilepsy is in children?
Well, I think the first place to look is how common is it, altogether, because I think a lot of people don't understand that. And actually, 1 in 26 people will develop epilepsy at some point in their life, which, a lot of people hear that number and are astounded. A lot of people think, well, I've never known anybody that has epilepsy. But the fact is, you probably have. They might not talk about it, and that's why you didn't know, but it's quite common. As far as the overall frequency, you definitely see the incidence of epilepsy highest in the first years of life, as well as in the later years of life. So in the 60s and 70-year-old population, we see an increase there. But epilepsy can occur at any time throughout the lifespan.
That's an interesting point, and I'm glad you pointed that out. For example, later in life, even though you've had no previous epilepsy or seizures, it could occur, say, at age 50 or 60.
That's right. And, the reasons might change a little bit over time. Like for a young child, a new baby, it might be seizures related to something like a brain malformation or something like that. And that's not likely going to present in an adult. But, an adult later in life might have it because of head trauma, or maybe they have it related to a stroke or something like that. So the reasons may be somewhat different, but the possibility exists throughout life.
For parents especially, obviously would be extremely concerned if their child had a seizure. But that doesn't automatically mean they have epilepsy, correct?
That's right. As we said before, epilepsy is the tendency to have more than one seizure. And to take that definition, a little bit further, it also needs to be an unprovoked reason. And so what do I mean by that? Well, if you have a seizure because, let's say, your blood sugar was low. If we correct your blood sugar and your blood sugar doesn't go low again, you're not going to have seizures again. So that's not a person that has epilepsy. They had a clear reason that was corrected why that happened. If you have as a child, a seizure with a fever, oftentimes that's a febrile seizure. The fever is what provoked it. As you get older, that goes away. That's not epilepsy. But if you have an underlying tendency otherwise to have seizures and they're going to be recurrent, that is when we would call it epilepsy.
In the children that you treat that are clearly diagnosed with epilepsy, are there different forms or kinds of epilepsy?
There are. There are lots of different kinds. I think it's easiest for people to think of it first as focal epilepsy versus generalized epilepsy. So focal epilepsy means an epilepsy where the seizures are originating in one area of the brain. And then they might spread to other areas, but they always start in one area. And then generalized epilepsy is a type where the seizures kind of start almost in the whole brain at one time. And the seizure types might be slightly different between those two, and the reasons for those epilepsies might be slightly different. And of course, there's going to be a big population where, despite taking a good history and getting a good description of the seizures, and you do the workup with EEG and MRI, we're still not sure if it's a focal epilepsy or generalized epilepsy. And then some people have mixed, and then all of those have different underlying reasons for why the epilepsy occurs.
You mentioned a good point, and I know you do a thorough history, but let's assume a parent had epilepsy and then they have children. Is there a tendency that the children could develop epilepsy?
And that's a good question that doesn't have a straightforward answer. So there are certain epilepsies where there may be or certain reasons for epilepsy where there might be a higher risk that you would have a child that would have the same condition as epilepsy. These are usually genetic disorders, like, for instance, tuberous sclerosis complex. If a parent had that, they've got a 50% chance that their child would have tuberous sclerosis, and then there's a high rate of epilepsy. For the overwhelming majority of epilepsies, while there may be a slightly higher risk in offspring in general, it's pretty low. Most people, have their own kind of sporadic reason for epilepsy, and that's not going to pass on.
What are some of the treatments available if you do have genetic epilepsy?
Well, that's an area that is, I think it's really exciting because a lot of things are changing. When I say genetic epilepsy, it's a pretty broad category, but I think if we focus on the fact that in the last, 10, 15 years, a lot of people who didn't really have an answer for why they had epilepsy, and now genetics are just getting so much better at identifying genes that are responsible for disease, we're starting to find lots of underlying genetic reasons. And some of those genetic reasons are in genes that we are beginning to develop therapies that might correct the underlying problem. Give you a good example. I treat a lot of kids with a condition called Dravet syndrome. And this is a condition where they have a genetic abnormality in a sodium channel in their brain. And this particular gene, we all walk around with 2 copies of it. And in a person with Dravet syndrome, one of those copies doesn't work really well. And that's why they manifest this epilepsy. And we are currently in the process of evaluating a couple different approaches where we can give treatments that actually, for lack of a better word, attach to the good copy of the gene and make it create more of the healthy sodium channel so that we can replace the one that's damaged. So these are approaches that actually go at the underlying genetic reason for the epilepsy, which is different from what we do for most everything right now, right? Most all the treatments we have now are medicines that are going to treat the symptom of the seizure, but not treat the reason for the seizure per se. And so it's pretty exciting.
You mentioned that there are treatments available, I guess, in medication form to treat the symptoms. Is prescriptions and medications used frequently currently to treat epilepsy?
Yeah, we've got lots of different medicines we can use to treat epilepsy, and they work in different ways. They may work on different channels. Some may be better for some seizure types than other seizure types. Some might be better for certain syndromes than others are. So each medicine really just has to be chosen on the patient's history and their epilepsy diagnosis to find the one that's best for them. But also, as we said, medicine doesn't work for everybody. About 30% of people that have epilepsy will be what we call pharmacoresistant or drug-resistant, meaning that they have failed at least 2 medicines. And once you have failed 2 medicines used at high doses, the chances that the 3rd medicine and beyond is going to make you seizure-free goes down significantly. And that's when we start thinking about, what other options do we have to treat your epilepsy?
I've heard there are some surgical advancements related to epilepsy. Can you elaborate on that?
Absolutely, yeah. Epilepsy surgery is probably the most underutilized yet most effective therapy for epilepsy around. Most people think, when you start talking about surgery, especially surgery on the brain, hey, that's a big step, right? And so people often will put it far down the list of things to think about to treat the epilepsy. But, for the right candidate, if surgery can be done safely and can remove the area causing the seizures and have a high likelihood of resulting in seizure freedom, it's significantly better than continuing to take medicines that, we know after a certain point your likelihood of being seizure free is pretty low. So we have lots of different ways to do surgery. The first thing is to identify, what type of epilepsy it is and where it comes from. If it's a focal epilepsy coming from one area, and it's an area of the brain that we think we can safely treat without causing harm, we may remove that area. We can treat it if it's small enough with what's called thermal ablation or laser ablation, where we just insert a small laser fiber and just burn the area that's causing the problem. For some people, some of the most exciting things now are what we call neuromodulation techniques. So this would be a technique where we've identified where the seizures come from, and instead of removing the area, what we do is place electrodes over that area of the brain. We have one device called a responsive neurostimulator where we implant it. It's basically a little computer that is reading the brain activity throughout the day in that area, and when it sees a seizure happening, it delivers an impulse, if you will, a little bit of electricity to stop the seizure. So that's pretty exciting. That's also that same technique, and another technique called deep brain stimulation can be used to treat kind of the center part of the brain called the thalamus, which can help decrease seizures for people with generalized epilepsy. So, in the past, epilepsy surgery used to only be thought of for people who, had a clear abnormality of the brain, a focal abnormality that was causing the seizures. But now the candidates for epilepsy surgery are much wider, and lots of people are good candidates to consider it as a treatment option.
1 in 26 people, a huge statistic. Dr. Scott Perry, head of Neurosciences at Cook Children's, with us talking about epilepsy here in November, Epilepsy Awareness Month. More advice for parents whose kids have epilepsy next on the Human Side of Healthcare.
Covering the healthcare topics that matter most to North Texas. This is the Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
And welcome back. November is Epilepsy Awareness Month, so what a great time to visit with Dr. Scott Perry, who is the head of Neurosciences at Cook Children's. If you or you know someone who is one of those 26 who have epilepsy, this is invaluable information. Steve?
So, Dr. Perry, how do you work with parents and coach them when they determine that their child has epilepsy?
Well, the first thing I tell them is I want to focus on that the majority of people, again, 60 to 75%, are going to be seizure-free and well-controlled on one of the first medicines they try. So that's the most important thing. And then I set the expectation that if that doesn't happen, that we've got a slew of other options to try to work and find that answer for the epilepsy. And then I just try to make it clear to them that we can't let this epilepsy define the child. All right, we've got to let them continue to grow and be a healthy, normal child and treat them that way.
It sounds like some of the innovation, too. You mentioned the laser treatment, and some of the other treatments are not as invasive as the past. Some are non-invasive, which also, right, I assume, is great for the patient.
Correct. I think it certainly helps by becoming minimally invasive. It helps increase the acceptance of the treatment option, right? So, for instance, some people may go through a workup for epilepsy surgery, and we don't know how good they are as a candidate until we actually place electrodes on the brain or in the brain to make sure exactly where the seizures are coming from. And in the past, the way we did that is we did a craniotomy, so you'd actually have to remove, the skull, expose the brain, and put these electrodes on top of it. And now we do a technique called stereo EEG. So instead of doing that big surgery, the neurosurgeon does small burr holes. So these are just small holes in the skull of a couple millimeters, and using robotic guidance can place little electrodes that are basically like thin piano wires into different parts of the brain. And we can do that monitoring with a much less invasive procedure, much less pain, and still get the information we need. And then if we can localize the abnormality to a small enough area, we can go through that same very small burr hole and use the laser fiber. And those people that have that kind of procedure will go home within a day. Go home within a day after brain surgery with limited pain and good outcomes. So it's exciting.
That's tremendous. Thomas and I love to hear about all the new, innovative, cutting-edge technology. So I'm going to kind of put you on the spot. if you don't mind, Dr. Perry, as you look in your crystal ball, what do you see coming out in epilepsy treatment, or what do you predict in the next 5, 10, or 15 years?
Well, I think the thing that's probably going to be one of the most exciting things is what we already started talking about, which was some of the genetic-based therapies. And the reason this is exciting is because a lot of these genetic conditions are really severe epilepsies, and they occur early in childhood. They significantly impact the children, not only with the seizures, but having all those seizures and the underlying genetic abnormality impacts their development, their behavior, their sleep. Obviously, their families' lives are affected. And if we can correct that genetic abnormality through some type of gene therapy or modulation of some type, that is going to be a huge game changer. And as I said, we're starting now, like those trials are enrolling, and we're just at the tip of the iceberg for one type of genetic epilepsy, but there are hundreds, and I think that's really going to open a door for a lot of people who really didn't have any satisfactory treatment before. And then the surgeries that we talked about, they continue to get less and less invasive, and they continue to increase the number of people who might be good candidates for it. And that's important, because when you've got 30% of people who are not controlled with medicines alone, we've got to have other ways that we can treat their epilepsy. So I think those are going to be the two big things.
Hey, that's great. I love your predictions there. I need to ask this question. As you look at data and look at the epilepsy data accumulated over the years, is it impacting anything based on gender, race, ethnicity, or is it anyone can have epilepsy?
Anyone can have epilepsy. It does not segregate based on any of those categories you mentioned. Again, as we said at the beginning, 1 in 26 people, very common. So it's important for people to be aware of it. So I'm glad we have months like November in epilepsy awareness, so people can become familiar with it, learn the options out there, learn seizure first aid, learn how to recognize seizures, and help push for cures.
The comprehensive epilepsy program at Cook Children's is really recognized as one of the, I would say, prominent national programs. What do you think really sets your program apart from others throughout the country?
There's a lot of great programs in the country, no doubt. I think for us, one is the breadth of options that we offer. The extent of the different ways we can go about testing, trying to figure out what kind of epilepsy we're dealing with from a research standpoint, the number of clinical trials for new treatments, and then really just from a team standpoint, my team that I have here for pediatric epilepsy, many of us have been here and working together for 10 to 15 years. So we're kind of a well-oiled machine at this point, so I think those are the things. It's a good team approach with a nice personal touch, with a lot of tools in our hands to find the answers.
I read somewhere, and I don't know how true this is, that some people with certain forms of epilepsy have a medical service dog that can detect right before they're going to have a seizure. Is that true, or is that a myth?
No, that is true. There are seizure alert dogs that can be trained to recognize seizures. For some, maybe it is a scent that they pick up on that, obviously we can't. Or maybe it's just, just like, many parents can pick up on a seizure occurring or about to occur before, anybody else would, because they sense a slight difference in maybe the facial expression or the behavior or whatever. And so, those dogs are there and they do great work. They can alert people that it's happening. They can make sure that the person having the seizure is in a safe position. They can be trained to bring medicines to them. There's lots of different things they can do. So it's a real thing.
That's fascinating that they're trained to bring medicine. That's amazing. Dr. Perry, to our listeners, especially parents that may have children that have been diagnosed with epilepsy, or even adults that may have epilepsy. Do you have any final thoughts for them on treatment and how they can do everything they can to live a very productive life?
Yeah, absolutely. I mean, epilepsy cannot define the person, that is for sure. And I think you need to remain positive, which I know is hard to do when you have something like epilepsy, which is such an unpredictable condition, because you never know when a seizure is going to hit. But I think people need to know that there are lots of treatment options out there: medicines, surgery, new medical treatments, dietary therapy, neuromodulation, all these things I talked about. So, until you've exhausted the entire list, there's still a chance, and you need to keep looking and trying to find that chance. And on top of that, I would say if you don't have the answer for why you have epilepsy, you got to make sure you're continuing to look for that, especially if you don't have a reason yet and there's not been maybe genetic workup done, for example. Because, as I tell some of my patients when we do that testing, we might find a reason that we don't have a treatment for right now. But if you don't know what your reason is, you've got no idea what you need to be looking for to know when there's a treatment available for your particular reason. So we just want to make sure we're turning over every leaf out there to make sure we get the answers.
We've been listening to Dr. Scott Perry, the head of Neurosciences at Cook Children's, talking about a true human side of healthcare issue, epilepsy. Steve?
Thanks, Thomas. We hope you've enjoyed our show today. And by the way, we hope you had a great Thanksgiving holiday with family and friends. Join us next week for the human side of healthcare.